Florida as an opt-out state, a presentation by Rachel Kaplan, Ashley Kelly, Michelle Martinez, and Daniel Orozco, in affiliation with the Nicole Wertheim College of Nursing and Health Sciences at Florida International University. Healthcare spending is at an all-time high. United States healthcare spending grew 3.9% in 2017, making healthcare just over 17% of the nation's gross domestic product, or GDP. Healthcare spending is projected to grow faster than gross domestic product per year over the 2018 through 2027 period, and as a result, the health share of GDP is expected to near 20% by the year 2027. This is a large part of the reason why finding ways to deliver more cost-effective care without compromising quality is so important to our government, citizens, and country as a whole. A major opportunity for savings could be found in anesthesia services by utilizing CRNAs to the full scope of their practice and training. For almost 150 years, nurses were the dominant providers of anesthesia services. Presently, 37,000 CRNAs provide 30 million anesthetics annually in the United States and represent 2/3 of anesthetists in rural hospitals. As alluded to in the previous slide, healthcare markets could work more efficiently and Americans could receive more effective high-value care if we remove and revise certain federal and state regulations and policies that inhibit choice and competition. We need an efficient, cost-effective solution, and CRNAs are capable of filling the void and being the solution. Medicare pays the same fee for an anesthesia service whether it is provided by a CRNA, an anesthesiologist, or both. The funds to pay the higher costs of anesthesiologists must be paid by the hospital, the healthcare facility, or the patient. Furthermore, a recent influx of newly insured patients following the 2010 Affordable Care Act has exposed several areas in which the current healthcare system is lacking, one of which is cost-effective anesthesia services, especially in the rural areas. Federal law states that for a hospital, critical access hospital, or ambulatory surgical center to participate in the Medicare program, the facility must comply with specific requirements, such as having a physician supervise all CRNAs. However, in 2001, the Centers for Medicare and Medicaid Services ruled that states may opt out of this federal supervision requirement. For a state to opt out of the federal supervision requirement, the state's governor must send a letter of attestation to CMS. The letter must attest that the state's governor has consulted with the state's boards of medicine and nursing about issues related to access to and the quality of anesthesia services in the state, and that it is in the best interest of the state's citizens to opt out of the current federal physician supervision requirement, and that the opt-out is consistent with the state law. Currently, 17 states have successfully opted out of CRNA supervision, and no state has reversed the opt-out once granted. As mentioned in the previous slide, 17 states have successfully opted out of CRNA supervision, and no state has reversed the opt-out once granted. The American Association of Nurse Anesthetists strongly supports CRNA education at its highest caliber. To meet the ever-growing demands of healthcare, a doctoral education for entry into nurse anesthesia practice will soon be required. Adverse events related to anesthesia are rare regardless of the provider. In fact, the mortality rate for the nurse anesthetist solo group was lower than for the anesthesiologist solo group in opt-out states both before and after opting out. The Army, Navy, Air Force, Indian Health Services, as well as combat support hospitals and forward surgical teams, all allow CRNAs to practice without physician supervision. CRNA supervision opt-outs are supported by various organizations, agencies, and groups, such as the American Association of Nurse Anesthetists, the Association of Veterans Affairs Nurse Anesthetists, 53 nursing organizations, veterans, the Military Officers Association of America, the Air Force Sergeants Association, other veteran groups and stakeholders, the AARP, and more than 75 members of Congress have all communicated support for full practice authority for CRNAs and other advanced practice registered nurses. Complacency and a lack of advocacy are seen across the nursing community, and CRNA legislation suffers as a result. Advocacy may be improved through education, writing letters or emails to Congress, attending town hall meetings and conferences, staying current on key issues, and volunteering at the state and national level. Lack of funding hinders research, policy advancement, and educational programs. Patients and the public must be educated in the value and importance of CRNA autonomy. Misinformation being spread by the opposition will gain traction if the public is unaware of the benefits and improved access to care that unsupervised CRNAs offer the community. The extreme variation in practice requirements and laws from state to state also interferes with the ability to advance as a profession. A review of the literature reveals several studies citing no significant difference in surgical outcomes or anesthesia delivery models between CRNAs and anesthesiologists. The combined undergraduate and graduate cost of CRNA education is 15% that of anesthesiologists. Graduate education costs for CRNAs are less than 1/4 that of anesthesiologists. Independent CRNAs provide anesthesia services at the lowest economic cost, and net revenue is likely to be positive under most circumstances. In fact, it has been demonstrated that healthcare organizations would benefit with positive net revenue in venues of low demand, such as rural areas. Medicare pays the same fee for an anesthesia service, whether it is provided by a CRNA, an anesthesiologist, or both working together. The funds to pay the higher cost of anesthesiologists must be paid for by the hospital, the healthcare facility, or the patient. Several external forces challenge legislation that is aimed at improving public access to anesthesia services from independent CRNAs. Organizations such as the American Society of Anesthesiologists and American Medical Association benefit from laws requiring supervision of CRNAs and therefore fight to restrict the autonomy of nurse anesthetists. Various methods may be used by anesthesia physicians and medical organizations to exclude or limit competition by nurse anesthetists, including exclusive care agreements with hospitals or managed care organizations and limiting student nurse anesthetists' access to clinical cases for training purposes. The results of research studies seem to vary dramatically based on the organization funding them. Despite evidence illustrating comparable patient outcomes, improved access to care, and decreased costs of allowing CRNAs to practice independently, studies funded and cited by those in opposition state otherwise. Currently, important public and private data collection efforts such as the National Ambulatory Medical Care Survey, the Center Studying Health Systems Change Surveys, and the Area Resource File do not collect sufficiently granular data on APRNs and CRNAs. Furthermore, those concerned about the independence of CRNAs are seeking to replace them with anesthesia assistants or other substitutes who do not have the training or education to practice without physician supervision. There is ample research in favor of unsupervised CRNA practice. A review of the literature reveals several studies citing no significant difference in surgical outcomes or anesthesia delivery models between CRNAs and anesthesiologists. An analysis of Medicare data for 1999 through 2005 finds no evidence that opting out of the oversight requirement resulted in increased inpatient deaths or complications. Adverse events related to anesthesia are rare regardless of the provider. Mortality rate for the nurse anesthetist solo group was lower than for the anesthesiologist solo group in opt-out states both before and after opting out. Alternatively, studies have been released arguing that independent CRNA practice has its drawbacks. One study found that nurse anesthetists take longer to perform the same services, and as a result, may translate into equivalent or higher anesthesia costs overall. Another stated that no improvement was found in access to inpatient surgical care in opt-out states, which contradicts the argument that CRNAs will especially benefit access to anesthesia for those in rural areas. Many physicians claim the data is skewed because CRNAs do not perform high acuity cases, which is why their outcomes are comparable or better than physician anesthesiologists. This slide summarizes the many ways in which unsupervised CRNA practice offers cost-saving opportunities, some of which were touched on previously during the presentation. Studies show that independent CRNAs provide anesthesia services at the lowest economic cost. Healthcare organizations would benefit with positive net revenue in venues of low demand, such as in rural areas. Graduate education costs for CRNAs are less than 1/4 that of anesthesiologists. CRNAs practicing independently are 30 to 34% less expensive than anesthesiologists or supervised CRNAs. Presently, there are plenty of professional organizations and government agencies that support opt-outs. It is worth noting that the opposition is composed of physician-run organizations. If physicians stop viewing CRNAs as a jurisdictional threat and instead recognize them as crucial contributors that they are, America's healthcare system will improve dramatically. As highly skilled and competent providers, CRNAs must be permitted to deliver anesthesia services to the full extent of their education, training, and licensure. Ultimately, further research and randomized studies must be performed to properly defend CRNA's scope of practice. This concludes our presentation.